Unmute करा. Right, unmute करा. Right, video done. Right. Right, can you all hear me?
Yes, sir, we can hear you.
Okay. Hari Sampath. Right, so today we are going to discuss about pregnancy in an incorrect location. If you look at pregnancies, most of the pregnancies take place inside the uterine cavity. So, and out of the cavity also, there are places it get implanted frequently. So any other site other than endometrium is termed ectopic pregnancy. It could be anywhere, anterior abdominal wall, cervix, right? Though it is still the endometrium, cervical pregnancy is considered as an ectopic pregnancy. Generally, the characteristic of this pregnancy is they will not progress into full pregnancy, except rarely abdominal pregnancy. Right, so that is the definition, and it's the incidence varies. When I was a student, the incidence what I saw is different to what you see now because of the IVF and various. And then we look at pathophysiology, how it happens, and what are the predisposing factors for ectopic pregnancy. And then how do these patients present and how would you manage this patient, right? So that is the basic management. I have put some case scenarios. We'll have a look at it depending on each scenario. Right, so not all the pregnancies come in the same presentation. They have similar presentation, and the presentation to a doctor can be different. So it's abnormal implantation of a blastocyst or a fertilized ovum outside the uterine cavity, and it's ectopic pregnancy. And incidence they have caught in UK. Incidence in UK, 11.5 per thousand. Now it has become 12, I think, more or less. And the problem in there is these patients generally sexually active young girl who has multiple partners, and then they get infected with chlamydia. And chlamydia is one of the notorious infections for a girl to have, because that is invariably associated with ectopic pregnancies. So these girls, without knowing they are pregnant, they keep on continuing with their life. One night she sleeps and ectopic ruptures, and then they never wake up. And post-mortem reveals that it's a ruptured ectopic pregnancy. So like that, there had been reported cases of death in the bed in UK confidential inquiries. In Sri Lanka, we still don't experience it that much. But I remember when we were doing internship, one of the batch top in our batch from another university has seen a female in the surgical casualty. Not seen, she has instructed the nurses after hard day's work. This patient has got admitted around 2 o'clock in the morning, and nurses have taken instruction over the phone. Acute abdominal pain, and the poor house officer has given ordered a pethidine injection. pethidine injection, and next day morning, finally a student who came to take the history found a woman. His patient is frozen and dead. Right? So the house officer that time is now a professor, and there was a very strong argument going about giving a patient, undiagnosed patient with abdominal pain, giving a dose of pethidine. You can understand the gravity. So these can come up even in the surgical casualty. Remember that, right? So that is one of the very unpleasant incidents happened to one of my colleagues, but we saved her. Nothing happened to her, right? But these mistakes can occur. But it is our duty to remind you about these experiences so that you will not make such mistakes in your practice. Never ever give a pethidine for a patient with abdominal pain if you don't have a diagnosis. What that doctor would have done is arranging an ultrasound scan to that patient before giving the pethidine. Ultrasound scan invariably will show a mass and a free fluid collection. So that warrants the urgent laparotomy. Right? So that is a trick she would have done. But at that time, ultrasound was not that frequently available. So nowadays it's available, but then you must have a very good clinical sense also. If a woman comes with abdominal pain to your casualty, no matter whether you are a surgical or medical law, except pediatrics, all three, if a woman comes with abdominal pain, think of ectopic pregnancy. That is my take-home message for you today. And there has been increasing incidents attributed to young girls getting multiple partners, multigamous relationships ending up in tubal disease, pelvic inflammatory disease, and then tubal adhesions and ectopic pregnancy. On top of that, many women take treatment for infertility. So there is a very high risk of ectopic pregnancy. Compared to 1 in 30,000, ART will give you 1 in 7,000, ART will give you 1 in 100 to 80% risk of having ectopic pregnancy. In other words, if you treat a patient for subfertility, if she becomes HCG positive, one has to seriously think whether the baby is in the correct position or not. So that's the message that I want to get across to you today. If a woman has previous pelvic surgery, subfertility, assisted reproduction, previous ectopic pregnancy, until proven otherwise, consider it can be another ectopic, especially if that woman is presenting with a POA and abdominal pain. Okay, now wake up, right? No one knows pathophysiology, but it's said to be related to tubal motility, tubal contractility. We give certain drugs, like say, after intrauterine insemination, we put the patient on progestogens, right? So these progestogens can cause reduction in the tubal motility. So egg comes and the sperm interacts and fertilization takes place. Because of the lack of tubal activity, the fertilized embryo may remain inside the tube. So very important that you don't give progestogens immediately after your IUI something. Give about 2 to 3 days, and after that you start the patient on progestogens for implantation facilitation, right? And then what really happened, when the pregnancy starts in the tube, the pregnancy cannot continue. It becomes a failed pregnancy, and because of that, the hormone starts dropping down. So this is why the endometrial shedding will take place gradually. So this is the sign what we call prune juice, or there is little bleeding inside the endometrium, which can mimic the sac. So that's what we call a pseudo sac in ultrasound scan, right? So those are the early features of ultrasound in ectopic pregnancy in ultrasound scanning. Right? So with the ectopic pregnancy, uterus will still undergo changes of early pregnancy. And after fetal death or fail, the endometrium will generate and shed, explaining the irregular vaginal bleeding that is often seen in ectopic pregnancy. We'll move a little bit on. And yes, uterus endometrium shows pseudosacs in transvaginal scan. That means collected blood inside the endometrial cavity that may look like an intrauterine pregnancy. And sometimes, rarely, you think the women bleeds and you go and do a DNC thinking it's a miscarriage, and the histology shows peculiar Aries stellar reaction. Then you immediately call the patient back and check for an ectopic pregnancy. So it's a retrospective diagnosis. If you see Aries stellar reaction in the uterine curettings, then think of ectopic pregnancy. But you don't go and say how you diagnose ectopic pregnancy. Immediately don't say Aries stellar reaction. You say, I diagnose the patient by clinical features and in the history, if the patient has previous surgery, subfertility treatment, previous ectopic, and she at a higher risk, and then clinical finding of missed period and low abdominal pain with abdominal tenderness, guarding, and evidence of free fluid are clinically diagnostic of ectopic pregnancy. And I would like to confirm it by doing a serum beta HCG and a transvaginal ultrasound scan. That is how you should answer. Then if someone asks, what is the Aries stellar reaction? Yes, sir, it is diagnosed by retrospect. If someone does a curettage and they found Aries stellar reaction in the histology, then one has to suspect ectopic pregnancy. So sites of implantation, like I have told, normal site is this, where I have put my cursor. Any other places, cervical, interstitial, cornual, all these will be ovarian and abdominal. Abdominal. Yeah, abdominal. All these are ectopic pregnancies. Right? So cervical ectopic pregnancy, at the moment there's patient in Castle Street. You all seen. They are monitoring. And now they are giving methotrexate, because treatment for cervical ectopic is you remove this part of the uterus or top part of the uterus. So if the woman is pregnant for the first time, that is not possible. So we need to kill the fetus and trophoblastic tissue by giving methotrexate. Right? And this is another site, very difficult. If it ruptures, there is my final year question. I was given a specimen by Professor Hemantha Senanayaka. At that time, he was Dr. Hemantha Senanayaka. And there is, this specimen is there in our specimen lab. Removed uterus with ruptured cornu. So Hemantha Senanayaka was very fond of asking, tell me how this patient would have presented. So all the students started saying, abdominal pain, missed period, and typical ectopic thing. Whereas I think I provided the correct answer. This patient would have presented as a collapse patient, because you don't remove a uterus unless the patient is collapsed and dying. So he was very happy. I think I got a gold medal for my gynecology, because people expect you to answer rationally. You don't remove a uterus unless there is torrential hemorrhage, life-threatening hemorrhage. So life-threatening hemorrhages won't present to the clinic. They generally present to the casualty collapse patient, right? And all these places, you may not have to remove the uterus. You only remove the ectopic or the part of the tube. And then another challenge is the ovarian pregnancy, right? May need to remove the ovary at times. And I have seen rare occasion the ovarian pregnancy continues. Extra uterine pregnancy, they continue to healthy living babies. It happened at Peradeniya when I was a registrar, right? So the diagnosis was made at the time of the cesarean section, right? So remember, all these may not rarely. Some of the extrauterine sites can continue the pregnancy until term. I have seen 2 abdominal pregnancies with normal babies and 1 ovarian pregnancy with them. But in the tube, they will never continue to live pregnancies. Remember that. Right? Only ovarian and abdominal pregnancies can continue to term, but cervical, interstitial, tubal, all these places, they rupture and then they come with bleeding, collapse, pain, and all that. Right. So sites of implantation, trophoblasts invade the epithelium of the tube and deeper muscular walls causing erosion, hematoma, and tubal dilatation. This might explain the pain that precedes. Pain precedes due to expansion of the tube. Thereafter, due to hormone drop, a residual disturbance, the patient will start leaking blood. And if this continues, this hematoma rupture and will lead to serosal rupture and hemoperitoneum. That's what happened, right? Okay. Then rarely the tube can expand and the fetus can, the embryo can get aborted into the abdominal cavity. That's called tubal abortion. So sequelae of ectopic pregnancies, you can have ectopic pregnancy and then get self-limited and get absorbed, or it can expand, forming a hematoma and a tubal mass. Further expansion will cause rupture and hemoperitoneum, or rarely it can get aborted through the tube into the abdominal cavity. So depending on different sequelae, the management is different. Right now, for instance, most of the pregnancies I said, they on its own they die. You don't have to do anything, so you can manage conservatively. The ones which have got ruptured and hemoperitoneum, expanding hemoperitoneum, are the ones which needs the surgical removal. Right. So implantation of live pregnancy leading abdominal, ovarian, cervical pregnancy. I still don't want to talk about it. Sometimes lower sacs. I had one patient, sac was in the almost cervical portion, but the pregnancy expanded and when continued to become a live pregnancy. But lower cervical pregnancies never expand and they rupture, can lead to torrential hemorrhage requiring a hysterectomy. So that is a very dangerous situation. So you play it by ear. You see a sac in the lower cervix and you continue the pregnancy. See if the sac is getting expanded and the baby started growing, you think that the uterus is giving space to the baby, right? Otherwise, it's a lower cervical portion, which I have indicated in the previous diagram. This position, this will never go through. I have to disturb you for a second. I'm getting an urgent call. Give me a minute. I'm coming back. Right. Okay. Sorry, there was a telephone conversation. Right. So cervical ectopics, I said they'll have a different outcome. And then what causes an ectopic pregnancy? Tubal damage, tubal intima has to be, if you look at the tube, the size of the tube is similar to this room where I am, right? Your embryo is you and you are going through a big tunnel. That is the proportion of an embryo and the tube. Though it looks very fine, there is quite a space for the embryo to traverse through. And if there's any infection, you get all kind of adhesions that lead to stopping of the embryo. Not only that, sometimes the tubal motility is gone due to adhesions or due to progestogens, right? Some of the bacteria, PID or salpingitis, there is a 7-fold risk. Example, chlamydia, gonococcal, and tuberculosis. If you see them, there is a risk of intratubal adhesions. Previous tubal surgery. And one of the very important things is past history of ectopic pregnancy. This is the catch. Like I told you yesterday, if you learn this course to treat a patient, if she comes in the second pregnancy, think of ectopic, this pregnancy also, second pregnancy also. So you offer an early ultrasound scan to see whether that baby is intrauterine or extrauterine. That is the important thing of knowing these etiology risk factors. When they come with a previous ectopic, you always do an early scanning and confirm because she runs a higher risk of another ectopic pregnancy. Right, so when you practice, you see this is very, very handy, these lectures, the little ideas. And also you have an idea if the patient has an intrauterine contraceptive device, if the patient has assisted reproduction. And nowadays we see couple having sex and then loading them with 2 to 3 times all weekend, have sex and then take one emergency contraception. So by the 2 days, if there is conception, embryo is formed, Monday women take within 72 hours, 72 hours to 80 hours, they take the Postino 2. What happened? Now embryo is formed and with the large dose of Postino, levonorgestrel, the tubal motility is gone. So your Postino 2 is very strongly linked to the occurrence of ectopic pregnancy. If you are taking Postino 2, take it soon after the unprotected intercourse. Don't collect things and economize on Postino 2 or 1, whatever, right? And then pelvic infection, pelvic surgery, and pelvic endometriosis are also known to cause ectopic pregnancy. If you get a patient with pelvic endometriosis suddenly becoming pregnant, offer a scan. If the patient had a previous tubal surgery, previous ectopic pregnancy, offer a scan. If the patient has a pelvic infection, if the patient has taken Postino 2 and she didn't get the period and beta HCG positive, think of ectopic pregnancy. Clinical presentation, it's an early general presentation because of the tubes cannot expand, 5 to 12 weeks gestation, and the lower abdominal backache or pelvic pain, usually unilateral. And vaginal bleeding, due to drop in hormone, the endometrium starts shedding. It's scanty, dark, and intermittent. That's called prune juice kind of thing, right? So these are all these 2 symptoms are the early symptoms. Women miss the period and then lower abdominal pain with a shooting kind of pain, right? And sometimes getting faintish also. If you miss this stage, she would rupture and she become hemodynamically compromised and then blood tracks into the diaphragm and you get your typical shoulder dip pain and due to diaphragmatic irritation, and then syncopial attack, right? So you have 3 levels of doctors who takes a history and look for risk factors, and she has become pregnant, beta HCG, and she has abdominal pain. Our sir has told any pain, abdominal pain with the POA, it's an ectopic. So investigate. Or you have another lousy doctor, oh, don't care, you may be pregnant, you may not be pregnant, who knows? But abdominal pain is there for any women. Find a woman without abdominal pain. And then she comes with this syncopated state of the collapse. Then he will be a bloody hero, putting IV line, doing a big mini laparotomy. It is not accepted for a good doctor. A good doctor will find it at an early level, looking at the risk factors and etiological factors which I have mentioned, right? So when you practice, be more vigilant. That's a key word. Don't try to be overconfident, right? No harm in over-diagnosing ectopic pregnancy, but always there's a price for not diagnosing. That's the price is a life of a patient. Remember that. Currently, nowadays, and I will be the president of the College of Obstetrician. We give no chance for any junior to miss an ectopic pregnancy. It will be very severely dealt. So my advice for you is overdiagnose ectopic, rule out, do a beta HCG and scan, then your life is done, right? So do that when you are in the internship, because you are the person who will be in first touch with these patients. Then shoulder dip pain and syncopial attacks indicates rupture and hemoperitoneum. So this is the golden statement. Any sexually active woman presenting with abdominal pain and vaginal bleeding after an interval of amenorrhea is an ectopic until proven otherwise. Remember this, you will save at least 10 or 15 women before you get your retirement. Management, initial examination should be for looking for vital signs, general examination, looking for pulse, blood pressure. Pulse rate indicates 10%, blood pressure indicates 20% loss, and no urine output indicates more than 30% loss. And then check for hemoperitoneum guarding rigidity, rebound tenderness, and decreased bowel sounds indicates hemoperitoneum. Vaginal examination will help in a diagnosis with pain and tenderness. But remember, if you don't have a surgical facility, don't do say you are in a rural setting where you suspect this patient and you want to transfer her. Do not do a vaginal examination, because your vaginal examination itself can rupture the ectopic pregnancy. You write, because there is a risk of rupture, the patient was not subjected for a vaginal examination. එතකොට අනිත් පැත්තේ ඉන්න ඩොක්ටර්ට මොකුත් කියන්න බෑ. You are a brainy person. During if you are performing vaginal examination during a speculum examination, cervix to be closely examined. Sometimes it could be a miscarriage. Who knows? POA and bleeding and pain. The products may be coming. In that case, don't try to diagnose ectopic pregnancy. If you see a single product, that will rule out an ectopic and that become a miscarriage. So your speculum examination is also very important. After all, pregnancy, bleeding, PV, 3 things you have to suspect: miscarriage, ectopic pregnancy, and molar pregnancy. So your speculum examination is an important thing. Now, the management I will discuss in forms of clinical scenarios. Otherwise, I will not be telling you these are the ways and nothing will go into your head. So if you have fallen asleep up to now, please wake up and at least listen to these three scenarios, which will give you a comprehensive touch on how we manage an ectopic pregnancy. Remember, I told you not every patient with ectopic pregnancy needs an operation. Remember, right? So we'll go through each and every one and let's look at how we manage different patients. Mrs. IVF presents after 3 weeks following IVF and embryo transfer, and ultrasound detects no intrauterine pregnancy. And instead, see a donut ring shell pseudo sac. So you know, obviously IVF done and the pregnancy test is positive. You say her beta H is 320, not a very interesting, exciting figure. Beta HCG should go above 3000, right? 3 weeks following embryo transfer, it should be at least above 5000. But 320 means she has conceived, but it's a failing pregnancy. Here, no baby inside the uterus. So obviously, it's an ectopic pregnancy. And she is clinically asymptomatic with no free fluid or masses in the transvaginal scan. Now, this is a kind of patient who is aware what has happened and she knows there's a risk of ectopic pregnancy because she has gone through an assisted reproductive technique and her beta HCG levels are very small and no masses. It's a very early ectopic and it's failing. So you let this pregnancy to fail and get it absorbed to the body. Don't do anything. This is a patient who only needs observation. You keep her in the ward, just say good morning, how are you, touch her abdomen, look for signs of any tenderness, look for free fluid, right? Anything like that, and then you keep her in the ward for about a week and discharge. So that is your conservative management of ectopic pregnancy. Do nothing but observe her fully. You got this? Understood? Everyone?
Yes, sir.
මෙහෙම આવොත් පුළුවන් ද මැනේජ් කරන්න අද්දකන ගිහිල්ලා තියටර් එකේ බඩ හරහා කපන්න ඕනේ නෑ මේගොල්ලන්. තේරුණාද? Just speak to her and keep her reassured. But she asked you, doctor, can I go home and come back? No. Can I have a little intercourse with the husband? No. You keep advise her. Right? If she is living next door to the national hospital, yes. But no sex, no going out. If there's anything, you immediately report to the ward. Right. And then clinical case 2. Miss E.T. present at 8 weeks with severe lower abdominal pain and feeling faintish with pain. මෙයාට හොඳටම අමාරු වේගන යනවා දැන්. Ultrasound reveals empty uterus with a mass in the adnexa. In closer look, visible fetal heartbeat seen. Where is the baby now? In the adnexa. So this is a very, very peculiar situation. The baby is alive, very active. If you rupture this, she would die in seconds. So this is a kind of patient. Invariably, she needs a laparoscopy or laparotomy to remove the ectopic mass. You don't do a self-ingotomy, but you completely remove the tube, saying self-ingectomy. Remove the ectopic area along with the tube because you see a live fetus and then put a knot. That tube cannot be used thereafter. So, clinical case 2 of Mrs. E.T., 8 weeks, with evidence of rupture and a mass with viable fetal heartbeat needs to be operated. So, you can have extended matching, you can have 1000, best of 5, and whatever, best is to remove that tube. So self-ingectomy, either open or close self-ingectomy indicated. Right. So come back. So this is a patient who has a ruptured ectopic suspected with a viable fetal heartbeat. So she needs a definite self-ingectomy, either open or closed, whatever, mini laparotomy or laparoscopic self-ingectomy. So self-ingectomy is the answer. Mrs. R present at 8 weeks with severe low abdominal pain and spotting blackish blood. Transvaginal scan reveals empty uterus with a mass in the adnexa 2 to 3 centimeters. So she is all right. She has pain, spotting, and no hemoperitoneum. But there's a mass of 2 to 3 centimeters and somewhat active ectopic pregnancy, 1,000 to 3,000. So you can't say conservative also. ඒකත් බයයි නිකන් එක වැඩෙනවනේ ළමයි. So next day like operating also, because Mrs. R said that doctor keep me without an operation. Yes, it's possible, and this Mrs. R can be managed effectively with methotrexate. 1,000 to 3,000 and no viable heart, 2 to 3 centimeters, and no evidence of rupture can be considered for medical management methotrexate. Okay. Right, so it's a typical one, so you can have your own guesses about your patient, taking these cases as example. So this is indicated for medical management. Finally, Mrs. R has not received the medical management. She has gone home, and the ectopic starts growing up and brought to A&E. 140 blood fluid, and she's short of breath and very pale with shouting in shoulder tip pain. So now it's a ruptured ectopic pregnancy. Mrs. R definitely needs no time for laparoscopy also. Definitely need the cut. It could be a mini laparotomy and then arresting of the leader of a ruptured ectopic, and then maybe she needs a transfusion after the surgery. So this is an indication for a mini laparotomy because it's a ruptured with hemoperitoneum and removal of all the blood in the peritoneal cavity. So I have discussed 4 different scenarios and 4 different ways how we could manage this patient. So I hope you go home and read up about it. And these are the case scenarios that you will see identically in your life. Right? So I'm a person who will teach you in a very clinical way. So this is how I do my lectures. I can give a descriptive lecture about laparoscopy As an intern, you read this lecture twice and keep it in your mind and then practice. You'll be a safe doctor. I don't want a person to come and teach me, you use laparoscopic laser, this and that. At your level, it is not necessary, right? You should protect your consultant with this knowledge as a intern house officer. So we'll call it a day and relax. Thank you.
Thank you, sir.